This procedure video will take you through the technique of performing an emergency cricothyroidotomy in either an adult or pediatric patient. This is one of the truly emergency procedures that most of us will never have to perform. However, in the MChem OSCE examination, the availability of mannequins mean that this procedure can easily be assessed. As in all procedures, it is important to maintain universal precautions at all times, including hand washing and wearing of gowns, gloves and goggles. Take time now to familiarise yourself with the equipment shown above, as well as refreshing your memory of the anatomy of the neck.
So this is demonstration for needle cricothyroidotomy. First locate the cricothyroid membrane, locate the thyroid cartilage, work way down, and the junction between the cricoid cartilage and thyroid cartilage is the cricothyroid membrane. Once we identify the site, clean the location. So, take grey or white cannula, fill up a 10 ml syringe with normal saline, going back to the location. The needle directed towards the foot at around 45 degrees angle. Insert with aspirating. Once we are in, get the bubbles in the syringe. Advance the cannula holding a trocar. Put the sharps in the sharp pin. Now you can connect the cannula two ways depending on what we got in the department. The easiest thing we can find is the oxygen tubing. What we do is cut the oxygen tube on one side. Now I can fix this end to the cannula. Connect the other end to the jet insufflator. Inject oxygen at a ratio of 1:4. Hold the hole, block the hole for 1 second, and then release it for 4 seconds. If you got this type of tubing, get a Y connector. Connect the oxygen tubing and the other end to the cannula. Open the port here and the same at a ratio of 1:4. Hold it for 1 second and release for 4 seconds. 1 second, release for 4 seconds.
It is important to remember that performing an emergency cricothyroidotomy is a last-ditch effort when there is obstruction at or above the level of the larynx. This is a procedure simply to bypass the obstruction and to buy yourself some time by ventilating the lungs. By sticking to the midline, complications should be minimal, however bleeding and formations of fistulas are possible. ENT and senior anaesthetic support should always be en route.